Good morning. Thank you for the invitation to speak. So I'm just going to spend a few minutes discussing the management of moderate functional ischemic mitral regurgitation, CABG only, or mitral valve repair in addition. And I'm going to start with a case of a 51-year-old gentleman who was in NYHA class 3. He had an inferior myocardial infarction. He had 3-vessel coronary artery disease, which was amenable to CABG, and he had moderate ischemic mitral regurgitation and a non-viable inferior wall, as we can see here. So how would we manage this patient? Medical treatment, coronary artery revascularization alone, or mitral valve repair in addition, or would we replace the mitral valve? We know if we treat these patients medically, the outcome is not good. As you can see here, patients with moderate or severe MR, probability of death is about 4 times higher than those with no ischemic mitral regurgitation. And so is the probability of hospital admissions for heart failure. So medical treatment alone does not give a good outcome. We know also that if we just revascularize this patient, the outcome is also not good. And this is a survival curve of patients undergoing CABG. In those with moderate mitral regurgitation, you can see that the odds ratio for death is 1.5 times higher. So even with revascularization alone, the outcome is not good. Of course, this worst outcome may not have anything to do with the mitral regurgitation, but may just be a reflection of the underlying poor left ventricular function of these patients. So the question we have to ask is whether if we repair the mitral valve, we would improve the outcome for these patients. What happens to the mitral regurgitation per se? Well, we know there are a lot of studies, and all of the studies are consistent that if we operate on 2+ MR with just CABG, about half of them will improve in terms of the mitral regurgitation grade, and about half of them will remain as moderate or will progress in severity. We know the most common technique to repair ischemic mitral valve is an undersized ring annuloplasty, which should be complete, and we should ensure that no more than trace mitral regurgitation at the end of the operation. So this is another example of a patient, a 65-year-old male who was in NYHA class 3. He also got angina exertion, 3-vessel coronary artery disease. He had moderate mitral regurgitation and a moderate LV systolic function. And in this case, this patient had 4 coronary bypass grafts and also a mitral valve annuloplasty, and these are his results. His echo a year later. You can see a good result with no mitral regurgitation and good coaptation of the mitral valve leaflets. 2 years ago, we presented this study here at the American Heart Association, and this was published in Circulation on the same day. These are the results of the RIME trial, coronary artery bypass surgery with or without mitral valve annuloplasty in moderate functional ischemic mitral regurgitation. And in this study, which was predominantly done in the UK, we recruited patients from 7 centers with moderate ischemic MR and randomized them into 2 groups. In the first group, they just had CABG. In the second group, they had mitral valve repair in addition, following all the principles which I've described. It was predominantly patients in the 70s or an older age group. Most of them were in NYHA class 2 or 3. The ERO was put between 0.8 to 0.2 and the regurgitant volume between 30 and 35. At the time this study started, there was consensus that this was moderate ischemic MR, but of course with the new guidelines which have just been published, I think this is at the borderline between the upper end of moderate and the lower end of severe ischemic MR with these quantitative criteria. And these patients all had moderate LV dilatation and moderate ejection fraction. The mean bypass grafts was between 3 and 4. Not surprisingly, patients who had the valve repair had a longer operation, longer bypass time, longer cross-clamp time. All of them had a complete ring annuloplasty. A third of them had a balloon pump use in both groups. A lot of this was elective, considering the high risk of these patients. Blood loss was similar in both groups, although there was more blood transfused in those who had a mitral valve repair in addition. Complication rates were not significantly different between the 2 groups, although the patients who had a valve repair had a longer hospital stay. Survival and hospital admission at 1 year was similar, although this study was not powered to detect survival or hospital admissions for heart failure. What was striking when we followed these patients up at 1 year, and this was the primary endpoint, was that in patients who had the valve repair, the peak oxygen consumption increased significantly better, 22%, compared to a non-significant change of only 5% in those who had CABG alone. And this was associated also with a greater reduction in LV volumes, 28% reduction in those who had the repair compared to only a 6% change in those who had CABG alone. Of course, the MR grade reduced more if the valve was repaired. Most of them who had the valve repaired had no MR at 1 year, compared to those who had CABG only, in whom most of them still had either mild or moderate mitral regurgitation. And BNP was also significantly reduced more in those who underwent the valve repair. In terms of their symptoms, those who had the valve repair also felt better. The median NYHA class was class 1 in those who had the valve repair, compared to class 2 in those who had CABG alone. So what do the guidelines tell us about how we should manage moderate ischemic MR? These are the European guidelines. And you can see that it says that surgery should be considered in patients with moderate MR undergoing CABG. It gives this as a class 2A indication, level of evidence C. This is the American Heart Association guidelines. It says that mitral valve surgery may be considered, so a less strong recommendation, may be considered for patients with chronic moderate secondary MR, stage B, who are undergoing other cardiac surgery. And it gives this as a class 2B recommendation, so a less strong recommendation. Level of evidence C, so no randomized trials, no references to this. And why is this? It has referred to the RIME trial as reference number 235. So it is referenced in the guidelines, but it has considered that as referring to patients with severe ischemic mitral regurgitation. And that's because, as we heard in the previous talk, the new guidelines suggest that an ERO of greater than 20, regurgitant volume of greater than 30 should be considered as indicating severe ischemic mitral regurgitation. However, valve hemodynamics is only one parameter in these guidelines. You can see that they have also indicated valve anatomy. And to indicate severe ischemic MR, it refers to severe tethering of the mitral valve leaflets and annular dilatation with severe loss of central coaptation. Whereas in moderate ischemic MR, it refers to mild tethering and annular dilatation with only mild loss of central coaptation. I do think there is a difference between an ERO of greater than 40 and an ERO of between 20 to 40, as in the RIME trial. As we can see, when we compare the results of the RIME trial with the Cardiothoracic Surgical Network trial, which I think Dr. Eka will present next, because the CTS network trial look at patients with an ERO above 40, whereas the RIME trial look at patients with an ERO of 20 to 40. So although the guidelines now refer to both groups as having severe ischemic MR, I think there are two different groups of patients, as you can see here. In the RIME trial, we had a recurrence rate of 4% at 1 year of moderate or more mitral regurgitation, whereas in the CTS trial, the recurrence rate of MR was 32% at 1 year. And I think this is almost certainly due to the fact that these are two different groups of patients. The RIME trial was in patients with an earlier stage of disease, whereas the CTS trial was in more severe ischemic patients. And this translated to how LV reverse remodeling, in terms of LV reverse remodeling, with the RIME trial demonstrating a very significant 28% reduction in LV volumes compared to only 10% in the CTS trial. As we heard previously, a lot of studies have been done to predict the recurrence of MR following mitral valve annuloplasty, and it has to do with two parameters: the tethering indices, and the coaptation distance is an easy thing to measure, greater than 10 millimeters, or the amount of LV dilatation, end diameter of greater than 65, or peprimus separation of greater than 20. When we look at the patients in the RIME trial, we can see that the tethering distance is only 7.7, so a lot less than the 1 centimeter. And when we look at the annular size in that study, you can see that these are the patients in the RIME trial. As we know, the mitral annulus changes in size, reaching its smaller size just before the onset of systole, and then progressing and enlarging just before the leaflets open. And we can see that there's loss of annular function in functional ischemic MR, but in this group of patients, the maximal annular size was not actually dilated, but what there was a loss of annular function. So in moderate ischemic MR, certainly in this study in the RIME trial, there was no significant annular dilatation. Another study on moderate ischemic MR published in a group from Italy reported very similar results to the RIME trial. They randomized 48 patients to CABG plus a mitral valve repair and 54 to just CABG, and you can see that those who had the valve repair had a better NYHA class, less MR grade, and a smaller LV at 5 years. Of course, we are all excited to listen to the results of the CTS network trial, which will be reported tomorrow on moderate ischemic MR. The design of this trial is very similar to the RIME trial, so I look forward to listening to the results tomorrow afternoon. In conclusion, I think I would follow the recommendations of the AHA guidelines with the new quantitation of definition of moderate ischemic MR, and that mitral valve repair, in addition to CABG in moderate functional ischemic MR, may be considered. And I would consider patients in the RIME trial and the Italian study as having moderate to severe functional ischemic MR, and that in this group of patients, it results in improved symptoms, functional capacity, and LV reverse remodeling. The results are best in the absence of excessive leaflet tethering and LV dilatation. The patient's operative risk and associated comorbidities are important considerations. So thank you very much for the invitation again. I'd like to invite you to Windsor in England next year. We are organizing a course on functional mitral and tricuspid regurgitation for the European Association for Cardiothoracic Surgery. Thank you very much. Yeah.